We're live.
All right, very good. Well, good morning, everyone. Welcome back from the Thanksgiving weekend. It's good to see everyone here. Hope you're all doing well and had some time to relax and take care of your family. So again, thank you for your time. It's not always great to schedule a long meeting the day after a holiday break. I know all of you are trying to catch up with emails and everything else, but we will try to keep this meeting short and focused. Again, a lot of great work that's occurring. We are working together right now to put together a report to the LBB. We'll be asking some questions just to make sure that my team is clear on a couple of facts as we put that together. But again, I think with that, we will still be able to complete this meeting much earlier than the amount of time that we have allotted and allow you to have some hopefully protected time to go back and do some emails and catch up. So with that, why don't I go ahead and start off with the official roll call. Let me start off with Baylor. Dr. Goodman.
I'm here.
Good. Dr. Williams.
Howdy.
Texas A&M, Dr. Liberzon.
Here.
Okay. Dr. Harper.
Here.
From Texas Tech, Dr. Wakefield. Sarah Wakefield on yet? Nope, I don't see her. Dr. Trevino. Okay. From Texas Tech, El Paso, Dr. Thompson.
Here.
And Dr. Martin.
Here.
From University of North Texas Health Science Center, Dr. Podowitz.
Here.
Dr. Kasey.
Here.
From Dell, Dr. Nemroff.
Here.
Steve Strakowski. From MD Anderson Cancer Center, Dr. Tan or Dr. Robert. From UTMB, Dr. Wagner.
Here.
And Dr. Vo.
Here.
From UT Health Science Center, Houston, Dr. Suarez.
Here.
Dr. Newland.
Here.
Great. From UT Health Science Center, San Antonio, Dr. Plitzka. Haven't seen him yet. Dr. Blader.
Yeah.
Okay. From UTRGV, Dr. Escamilla. Or Mr. Patriarca.
Here.
Okay. From UT Health Science Center, Tyler, Jeffrey Matthews. And here, Dr. Matthews, Brittany Nichols.
No, I'm here. I just hit my mute button.
Okay. Glad I double checked, Jeffrey. Good to see you.
Thanks.
Brittany Nichols, I think I saw you.
I'm here. Yes.
From UT Southwestern, Dr. Taminga.
Yeah, I'm here.
Great. And Dr. Ibrahim.
I'm here.
From the Health and Human Services Commission, Sonia Gaines. And Mike Maples. So I didn't hear either Sonia or Mike. From the Higher Education Coordinating Board, Stacy Silverman, Dr. Silverman. I didn't hear anything there. From the hospital systems, Ms. Wesley.
Here.
Okay. From Meadows, Andy Keller.
Hi, Dr. Lakey. This is Shannon. I'm here for Andy for about the first hour, and then he'll be joining.
Okay. Thanks, Shannon. From the Hog Foundation, Dr. Martinez.
Here.
Good. From the Texas Council, Danette Castle.
Here.
And I'm here. Dr. Borges, are you here? And then a couple of people I think signed on after I started. From Texas Tech, Sarah Wakefield, are you here?
I am.
Very good. Dr. Trevino. From Dell, Steve Strakowski.
Yep, I'm here.
Dr. Tan and Dr. Robert, I haven't heard from you.
Dr. Plitzk's here.
Yes, I came on. Steve Blitzka.
Michael Iscamilla. or signing Mike Maples. So I think Naga, I think you totaled it as 26. Is that right? I think we have-
Escamilla is having some issues getting on. We're trying to get him an invite out.
Okay. So we have quorum. Thank you all for being here today. And as I noted at the beginning, I think we can get through today's agenda relatively quick. And again, appreciate everyone's trying to catch up, plus do this today. And so thank you for your time. So the first order of business is to approve the minutes from the October 29th meeting.
Move to approve.
Second.
I have a motion and a second. Any additional conversation? Hearing none, all in favor of approving the minutes, signify by saying aye.
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 Opposed, nay. Any abstain? We have unanimous approval of the minutes. Next, let's go into the updates of the different projects. For communications and marketing, I think I got a message here from Daniel Oppenheimer. I don't think there's anything new to update the consortium on. Luann, is that your understanding too?
Yes, that's right. In the October meeting, Daniel announced that the new website, the revised website, should be up and running at the beginning of next year. So hopefully at the December meeting, we'll be able to demonstrate that and show that to each of you. But otherwise, there's no updates.
Good. So then let's go to program evaluation by the University of Texas at Austin. Dr. Lopez?
Yes, hi, thank you. I'll be very brief. We are wrapping up our initial year evaluation report that actually will go in today. And again, we want to thank everybody for their efforts in sharing data and sharing your thoughts and perceptions with us. I think that's been very helpful. I think it's been a nice opportunity for us to dive into the data and understand a little bit more about the data transfers that have happened over time, kind of what data is available, especially in this early year where things were kind of being built as the different projects were getting launched. I think that gives us a much better understanding of the data that we have now and helps structure kind of going forward the data to try and be as clean and well-defined going forward. So we really appreciated the opportunity to dive into that. Hopefully coming up in this year, we'll be looking to be providing you with some quarterly updates that will help kind of keep us on track with data along the way now that the different components are up and running in most locations. So thank you all very much.
Well, thank you. We have this legislative deadline of December 1st for our summary of the activities of the last year. And so our team has been working over the last several weeks, including through this weekend, to try to put this in a way that does the best job as possible to represent the great work that you all are doing. And so we are, I was looking through it this morning, putting some edits together. I think that document will be ready to go. And by tomorrow, it needs to be sent in. We're ready to do that with some additional edits. And thanks, Molly, to you and your team for helping to spearhead a lot of that work.
David?
Yes.
David, I have a question. Is this the last time we'll get to update the legislature, or will we give a quarterly report in 2021 or a half-year report or something like that?
Yeah, I think we'll set to see what happens during the session, and there is a writer that helps determine our formal input, and so we'll see what they put in the writer. I imagine that there'll be other updates, as we go through. If this was a normal year, I think several of us would be testifying during the session related to the work that's taken place. We have remained in pretty close contact with the legislature, the LBB. We've had frequent conversations, and so they are aware of all the work. And I imagine there are several legislative offices listening to us right now that are hearing the updates. And so that they have been very engaged in this. And so I think they're very well aware. I think we may get some additional questions related to this report we put in tomorrow. But I don't know the exact pattern until we get a little bit further down. Does that make sense, Carol?
It does. Thank you very much.
Any questions for Dr. Lopez? Okay. Then why don't we move to the update on the research initiative. Dr. Kaminga, let me hand off to you.
Sure. Oh, thank you. You can tell why I was, you can tell from the data that I have why I was wondering if we could report in the future. I did give Luann a slide. If I don't know what should I put it up on the screen or will you guys? Luann, you're still muted.
John, can you go ahead and let us share screens, please? I can put it on.
Okay, that'd be good. The first slide just really will show you the supervisory team, which is, well, you can start with the first slide, which is Charlie Nemiroff, who's on the phone, with Duca Trevino, who I suspect is on the phone, and myself. And we've been really focusing on the research networks. What I'd like to do is just present one slide, and you can move to the next one, just one slide. And then Charlie Nemiroff will take over and talk more specifically about the Childhood Trauma Network. And then Maduka Trivedi will talk about the Depression Suicide Network in children. Now, there are several what I would consider landmarks. You know, the research didn't know that it was, we didn't fully as a committee decide to fund the research until fairly into the year, and then the protocols had to be written. The UT Southwestern is the common site for protocol approval, and the Depression Suicide Network overall received their approval in late July, and the Childhood Trauma Network in late August. Now, the UT system has a kind of a shared IRB approval. So it was fairly easy to get all of the UT sites approved with this UT Southwestern approval, but it's taken longer in the non-UT schools. But that was, of course, part of the project of these research networks, is to really to be able to create these research networks around the state of Texas. All 12 sites decided they wanted to participate in the research networks, and 12 sites are participating both in the Childhood Trauma Network and in the Depression Network. There's usually a distinct team at each of the HRIs for the Childhood Trauma and for Depression. There are 5 nodes, both for the Trauma Network and for the Depression Network, that are already entering cases. All of the 12 nodes, including the 7 who have not yet gotten to the stage where they can enter, are fully staffed and they're trained. All of the assessment tools and so forth have been shared and trained at all the nodes. And at most of the nodes that are non-entering, there still are some IRB issues. Both networks have created an electronic dashboard. And then I wanted to give you just a peek at the number of cases that have been entered the network already. In the Childhood Trauma Network, 66 individuals, actually a child and a family member, have been entered into the Trauma Network, on the way to 2,400 cases. The issue is that the pace of entry has started and is increasing exponentially, and that's the word they used, not me. The cases entered into the Depression Network and are 35, and these cases will be followed over time. The Depression Network plans to have 1,800 cases projected in the total network, and also in the Depression Network. The pace will increase exponentially. I suspect that if we did get another reporting period, David, we would be able to enter numbers in the many hundreds, because the pace of entry would suggest that. So with this as a kind of a background, I think that I would like to hear from, I would like to suggest that Charlene Emroff talk more about the childhood network, and especially why it's important for Texas, and then from Meduca Trevino to talk just a little bit about depression. Thank you.
Very good.
Carol, we could stop sharing the screen. I don't have any slides. I'm just going to give you a verbal report. And let me just start off and say that I couldn't be happier with how things have gone in the Childhood Trauma Network. So we recruited 15, we consented 15 subjects in October and actually 55 in November. So the total is now 68, 2 more than Carol actually showed you. And, you know, I have to say that Karen Wagner has been phenomenal as the co-lead, and Jeff Newport as the head of operations. So very briefly, we have 3 subcommittees in the Childhood Trauma Network, which involve members from nodes outside of the hub. That includes the Protocol Committee, the Acculturation, Ethnicity, and Participant Advisory Committee, and the Pilot Projects and Extramural Grants Committee. So several people that I'm looking at right now are on those committees, including Israel Lieberzon, Jair Soares, Michael Escamilla, and others. So this is truly a unified network of nodes. And as Carol said, the hard work's been done. We've done, for the first time ever, we've established a trauma network for children across the state of Texas, of which no other state in the country has done this. So this will be poised to be used in subsequent studies from other funding. I just wanted to tell you a little bit about what I hope David and the rest of you can highlight for the legislature. And I just want to read off to you the kinds of trauma that we're picking up. And the point I want to make is that none of these, hardly any of these children would ever have received any psychiatric or psychological attention if it wasn't for this network. So we've and some of them experienced more than one trauma, but just so you know, thus far, we've had 18 who've experienced a severe accident, 18 who've witnessed a severe accident, 17 natural disaster, which largely has to do with the hurricanes on the coast. We've had multiple children that were received emergency surgery. And then we have the more traditional psychiatric trauma, including extended separation of the family, physical or sexual abuse. We've had 9 that have experienced an attack from an animal, as an example. And then we have a variety of other bullying, sexual abuse, etc. What's really impressed me is the magnitude of the trauma, the severe quality of it, but also the quantity. And I think what the legislature needs to know is these kids, especially the ones that underwent medical trauma or surgical trauma, traditionally would never have come to the attention of mental health. And we're seeing quite a severe level of anxiety, depression, and imminent PTSD. So I suspect we have five of our nodes are recruiting currently, and the others are poised and ready. They've received a bit of an obstacle here and there with IRB approval locally and other such issues, but we're doing great. And I really want to give a lot of credit to our hub personnel and all of you for your support. I don't know if Karen might want to add something to my report.
I think what I'm impressed with is the collaborative nature amongst all of the academic institutions carrying out research that has never been done this way. It's just absolutely remarkable. And at the same time, it's helping to identify traumas that would not have been identified, even interestingly within the psychiatric setting, when, say, depression or anxiety is so prominent, sometimes people don't even see the trauma that's underlying it. So this really is, although it's a research study, it is so good for the mental health of children in the state of Texas.
Very good. Great update. Everyone was putting that together. Anything else, Dr. Nemiroff, on this network?
No, I think I'll turn it over to Dr. Trevino.
Great. Start. Dr. Trevino?
Thanks so much. And Charlie and Carol captured the three things. One is, I think that, and so I won't repeat too much of it, and I'll give you some details about the Depression Suicide Research Network. But one is, I think that we've now stood up a research network across all 12 medical schools, HRIs in Texas, that are actually have significant number of people trained and certified in research procedures. About 40 research assessors across these 12 nodes have been certified. They are ready and have been trained and certified in a number of measurements tools on depression, suicide. And the beauty of this sort of twin networks also is that there is a lot of shared training as well as shared procedures. Like Carol, Dr. Wagner and I and our team just had a meeting trying to sort of synthesize a common approach to suicide prevention programs in these, so that when there is a suicidal teen or a child, we have the same procedures in place, and we'll have that in very shortly. So that is really the first task, is to set that up. The recruitment part, I think, as Carol is mentioning, is clearly, once you start, then the procedures in place as they move on really speed up quite a bit. So while Carol mentioned the 35 recruited, in the time that we shared the report with you, and now we have 51 people already finished their screening assessments fully, and they'll be in the study. And that is related to the second part of the Depression and Suicide Research Network, and that we have instituted a longitudinal follow-up with measurement-based care and collaborative care. And one of the committees is chaired by Dr. Wakefield and Eric Storch and Jenny Hughes, that has trained over 50 clinicians in these 12 nodes to implement measurement-based care and collaborative care as outlined in national protocols, so that these programs are now implementing that. 20 of these patients have already finished the first month, and we now have records of their measurement-based care and how well that is done and what are the outcomes. We have several committees that are, as Charlie mentioned, so I won't again repeat it, that involve a lot of folks from all the nodes, including Israel and Michael Escamilla, Jair Suarez, Eric Storch, and obviously Dr. Wakefield is at the center of a lot of this. We have, did the kickoff training on July 29th. We had a two-part assessor training July 31st and August 7th. A database training. The database is now functioning, and it has actually all the elements of safety monitoring as well as data capture. We have monthly hub and node leadership meetings. We've had 9 of those with 50 plus individuals attending. So it is actually a vibrant, collaborative, 12 HRI driven network that actually is using uniform procedures and implementing measurement-based care. One little word about this, which is important, and I'll let Dr. Wakefield add to it. The idea of using measurement-based care in real clinical practice settings across these 12 HRIs, that sort of approach has not been taken anywhere in the country. And everybody talks about it, but implementing it requires several components, and I can elaborate if there are questions, but that is now in place and is being used. And the sample that we are getting, exactly what Dr. Nemiroff mentioned, I think these would not really get the attention, the kind that they're getting. For example, in our sample, half the teens that have been recruited, they have actually had a previous suicide attempt. So these are significant illnesses that are not just so that really requires serious attention, and I think that that is happening. I think that the database is there, and as Charlie mentioned, we have the dashboard that allows people to first get aware of what is happening in each of their nodes as well as across the network, and then add additional information as they accrue more patients. The database REDCap system is functioning and is very ready, immediately available for data capture and database export if there are questions about reporting those to either the executive committee or outside to peer review organizations. Again, as Charlie mentioned, I think we could not, in doing a lot of these, establishing a lot of research networks for specific research projects around the country, comparing that to this, where we are actually, the goal was to establish the research network. I think this has moved much faster than I would have imagined. And as Carol mentioned, the idea that the UT system has been really responsive and helpful to us to get IRBs across all these in such a short time, I think is a tribute to the system, and I appreciate everybody's help. And I have to second what Karen said. This is a very collaborative group, and it's been remarkable to see this. I'll let Dr. Wakefield add any more.
Well, thanks, Dr. Trivedi. I would just say, in addition to all of the wonderful things that Drs. Wagner, Trivedi, and Nemiroff have said, that for me, just the establishment of a network across Texas to improve screening and response for both trauma and depression for youth is phenomenal in and of itself. For the Depression and Suicide Network, I am just amazed by the hub team and the thoughtfulness that has gone into a project to be able to both take a snapshot of what's going on right now, to improve things in real time with measurement-based care training, and then also to help elucidate those targets for an improved system in the future. The ability to stratify those goals and to put in place metrics to achieve all of those goals will really position us well in the future for additional funding, but also to just improve the care for our youth in Texas.
And I think this variability that Dr. Wakefield talked about, both in terms of the sample that is getting into the research network for depression, suicide, in terms of variability, both rural, urban, underserved, insured populations, as well as treatment variability that's going to come out, is really going to be both scientifically important, but also my biased view is that it helps the legislature get a sense of where the resources are needed and where the resources are helpful, so that it can be used in the future to deploy resources adequately in the right places, so that we are not using a kind of a hammer to bludgeon the system, but actually be very precise and thoughtful about how these things work in different settings, because rural populations will have a different demand and a different set of outcomes than other places.
Great.
Very good. Any questions from the rest of the executive committee?
So this is Danette, and I do have a question. I think it's a follow-up to Dr. Nemiroff, and I really appreciated the examples of traumatic experiences, that broad range of traumatic experiences that children have who are now participating in this initiative, because it really helps to paint a very real picture of that. I am interested in, and may have just missed this, but you talked about the fact that these children and their families would not have likely otherwise been able to access care or treatment for these particular traumatic experiences. And so what are the ways in which, or maybe the primary ways in which children and families are actually becoming involved and become participants in this?
Right, so this varies from node to node, and that provides a really rich heterogeneity of subjects into the trauma study. So some of the nodes, like our node here, which is based at Dale Children's Medical Center, we're recruiting a number of subjects through the trauma service and the emergency department, as well as in the hospital. These are largely kids that have come in with auto accidents, with medical emergencies, burns, animal attacks, dog bites mostly, et cetera. So that's largely been, not exclusively, but that's largely been the traumatic population we have recruited in Austin. In contrast, Dr. Wagner has recruited, who's right there in terms of numbers, largely from the psychiatric clinic. And she could speak to the fact of much more traditional, quote unquote, trauma, including bullying, loss of a parent, sexual assault, physical assault, et cetera. As we look at each of the nodes, there's also some difference in terms of age of the subjects. So for example, Israel is focusing on the adolescent population and the 16 to 20-year-olds, and they'll come in with different kinds of trauma. So, and then there's the heterogeneity related to ethnicity. And I'm pleased to tell you that we now have completed all of the Spanish translations for all of our scales, and that's been submitted to the IRB as a modification. So we'll be able to be seeing that population, and we're working on the Vietnamese translation as well. So Karen, do you want to add to my response?
I think the response was very comprehensive. The ability to recruit from all of these different sites allows us to, I think, encompass all areas of trauma. It's hard to imagine that there wouldn't be a trauma that is not being seen at one of the sites.
Okay, thank you.
Very good. Any other questions?
I would like to just add a comment, if you wouldn't mind, to Danette, really. This doesn't happen in any other state in the country. I know that Charlie and Maduka already said that. But the reason that we've been able to make these kinds of advances that Charlie and Maduka and Karen and Sarah already talked about is because all of the sites of the HRIs in Texas are participating, and it's really very, this is the only state in the country. I hope you let our legislators know that.
Very good.
Important point. All right, thank you.
This is Potter Wilson. I just need to say that I'm really, really amazed, impressed, and proud of what we've been able to turn around and build and put together in such a relatively short period of time. I mean, the effort that went in to create these two study projects and to get it coordinated as it is, you guys, you're amazing. I mean, truly amazing. Good job.
Well,
I have to say, Alan,
Thank you.
Alan, I have to say you were you participated in this in the old-fashioned days when we had the chairs of psychiatry meetings. You were actually very supportive of the whole thing from the beginning.
Yeah, but this turned out, it's like magic. Thank you.
All right, if that's the message to the legislators, it's good enough for me.
And one thing related to what Dr. Pardovic is saying, I think that this also is now a shovel-ready set of networks that will be very ready for extramural funding immediately.
Mm-hmm.
That would not occur normally and would be competitive against any other such network in the country. And I think that is the other issue to keep in mind.
Absolutely.
All right. Very good. Great progress, folks. Anything else? Hearing none, let me transition to the next item. But before I do that, I want to recognize that Dr. Trevino has joined us. Anybody else? Is there anybody else from the executive committee that has joined us since we did the official roll call? Okay. Why don't we transition then to the external evaluation update? And Dr. Piskin and Dr. Salas, I believe I see you on the Zoom. Let me turn the podium over to you, Dr. Piskin.
Great, thank you so much. Naglo, you'll pull up the slides? Okay, great, thank you. So we just have a few slides. Thank you so much for having us here today. I'm here as well as Dr. Savas and two of our other collaborators for Rice, Dr. Moore and Dr. Tennant are also on the meeting as well. And we just wanted to provide an overview of the evaluation plan that we have proposed and to tell you a little bit about some of the activities that are going to be coming up soon. So as I mentioned, we're from the UT Health School of Public Health. We're working with other collaborators there as well, including Dr. David Larison, who is an expert in cost effectiveness research. Laura and I together, as well as our collaborators, we have a lot of experience in the development, implementation, and evaluation of theory and evidence-informed multi-level interventions, health disparities research. We're also partnering with Keonta Moore and Patrick Tennant at Rice University, and then also working with Decision Information Resources, and Sylvia Epps is leading our contract there. Move to the next slide. So our goals for year one are to develop an infrastructure to support a rapid cycle evaluation framework that allows for real-time program monitoring and improvement. Also to increase our understanding of best practices for program implementation across sites and potential impact of programs on equitable access to mental health assessments and ongoing services. And then we'll also be providing monthly reports, quarterly reports, and a final report at the end of the year. So we really want to build infrastructure, really be collaborative, participatory in terms of really helping to monitor and provide this external evaluation. Next slide. So we have several guiding frameworks that we proposed to use. We're basing it in the Centers for Disease Control, their conceptual framework for a program evaluation to engage stakeholders, describe the program, focus the evaluation design, gather credible evidence, justify conclusions, ensure use, and share lessons. We're also working, of course, very heavily with logic models, and we know that the group has already been doing that as well. And then we're also using a framework called RE-AIM, which is guiding a lot of our work. And this is a widely used framework that is used in development, implementation, and evaluation of programs, really focusing on reach. So looking at the reach of these initiatives, effectiveness, how effective they are, adoption, how are they being adopted, implementation, how are they being implemented, the factors that influence implementation, as well as what factors influence maintenance. So again, thinking about our goals, we really are planning to conduct formative evaluation, process evaluation, and outcome or summative evaluation. From now until probably the end of January, our goal is really to conduct a formative evaluation to really examine program inputs and planned activities, finalize our evaluation measures, really understand the data sources and reporting systems, and understand everything that's going on with the programs. For goal 2, this will be starting at about February through the end of the year. We'll be conducting a multi-level ongoing process evaluation to examine reach, adoption, implementation, and maintenance of the programs. And then for goal 3, which will be occurring simultaneously with the process evaluation, we'll be conducting an outcome or summative evaluation, and then also a cost analysis of the initiatives that are being implemented. The next slide. So just to talk a little bit more about formative evaluation, really what we want to do during this stage, and this is really the stage that we're in right now, is really to engage with stakeholders, to review and document the existing implementation plans, and document the current practice as planned through the use of process mapping. And I'll talk a little bit about what that is in just a minute. We're also working very closely right now in understanding the existing data sources that are available for the process and outcome evaluation. And we've had a few meetings already thus far to really try to understand all of the data sources that are currently available for us to draw from. And we're working on developing a matrix of all of those data sources so that we have a clear, comprehensive understanding of all of the data that's available. We've talked with Kosh already, we've talked with Molly, and we've talked with Nagla, and so we are compiling that information together. And then our goal is to really design and develop a database of existing data for analysis. One of the other major activities that we're going to be doing starting now and hopefully through the end of January is to do this process mapping protocol. And really what that involves is us really understanding and establishing a baseline of current practice for each of the initiatives, for each of the HRIs, as well as a sample of clinics and districts or schools engaged in the programs. And so our goal is to review the implementation plan already developed by the consortium in each of the HRIs, and to complete preliminary process maps, and also to build upon the process maps that have already been developed by the team here as well. And then we'd like to get input on those process maps from stakeholders, from the HRIs, and also from a sample of informants that are involved with clinics with CPAN, and then districts that are involved with TCHAT. And we will we'll start to identify people to interview and work with. We'll start with the executive committee and reach out to you all, and hopefully you all can let us know, if you can be interviewed and who else we should interview during this process. And so we'll be really completing those process maps for the various sites. The idea is that we sort of have this high level understanding of how it's supposed to be working across the different HRIs. And then we're going to look across the clinics and the schools to see how that's comparing, and then review that with program stakeholders. And then, of course, we'll update the logic models as needed. But the whole goal with the formative evaluation is really to, if you think about the guiding framework for the CDC, it's really to describe the program and really make sure that we understand the program and all of the outcomes that we're going to be collecting. So next slide. So Laura, do you want to take it from here?
Sure. Thanks. So after the formative evaluation, that really sets us up to be able to start examining measures for the process evaluation and some preliminary outcome evaluation effectiveness measures. So the goals of these two different stages are to increase understanding of the intervention. And this is following the REAIM framework. So REACH, implementation, and implementation includes fidelity of implementation and eventually the maintenance and sustainability in a more long-term evaluation approach. It will also look at building understanding of the characteristics of participants, or reach across different subgroups. And we've talked about equity and heard that even in the geographic, rural, urban context that you all were mentioning, and looking at engagement in different program components. So those are all components of the process evaluation. We'll also work to identify the facilitators and barriers to implementation across, looking at how that may vary in the context of that variation, the organizational and patient level. And then we'll examine the preliminary program effectiveness. And this is for again, this will set up the evaluation to have a framework for a longer term. So all of these different stages will be looking at our logic model to ensure that we have the metrics to do this, and working to ensure that this plan can carry forward in the future. Okay, we can go to the next. Thanks. So this will be conducted at both the level of the CPAN.
Is there
Sorry.
a place for a question right now?
Oh, okay. I don't know if someone's trying to ask a question.
Yeah, is there a place for a question right now?
That's fine, sure.
Are you planning to present the logic model to the committee?
We could. I don't think we have this on our slide deck here, but we presented logic models, and of course they're preliminary because during that formative plan, we'll look to ensure that they're reflecting what the actual implementation is, and the metrics are there to ensure that we could actually measure the components in the logic model. But we could bring that forward. Those are also the logic models would be something we bring to our stakeholders to reflect on and get verification. Are these accurately measuring and capturing the activities that are being planned for these, the CPAN, so that they're relevant? That's really going to be part of our formative work to make sure the relevancy is in place in terms of the guides that we set up to base the evaluation on.
Well, I think that will be important at some point during your formative evaluation or toward the end, whatever you feel like you got enough information from individual stakeholders to bring it to this committee as a whole for a brief discussion and say, are we really measuring what we believe is important? And that's the logic that you're talking about. So I think it would be good to discuss that briefly at some point, maybe whenever it's ready, 3-6 months, whenever you guys feel like you're ready with that.
That's a great idea that we could bring them here, because we want to get the logic models right. They will serve as our blueprint and guide for the evaluation plan. And also we, if you have suggestions for key stakeholders, we want to get a variety of perspectives. So of course, program planners, but then the implementers on the ground implementing the plan to see that it all is reflecting these various perspectives, and then bringing it back for feedback. That's another stage of the formative work. So we'll definitely note that to bring that forward here if that's possible. Thank you.
Thank you.
Yeah. So part of the formative work and then ongoing is the formative work will be identifying the data sources to build the database that could serve as the for our external evaluation. And then we'll start using that for the reports that we bring here monthly. So as we're monitoring the metrics for implementation, that will be an important component of our comprehensive evaluation plan. And it will be another point to make sure that we're on track, and it will in terms of focusing on areas that are important to the stakeholders. Then we'll also be developing and implementing online quantitative surveys. And these are right now planned for the mid-year and end year. And we'll want a representative sample of about 100 clinics. And the reason we ask for about 5 people per clinic surveyed is for some certain measures on organizational evaluation, you want different perspectives. So having 5 different participants gives you some perspective. For example, if we were looking at organizational culture or for change and readiness for change, you can't just base it on one respondent. So we're working with some implementation researchers on developing the survey. And then we'll have 5 focus groups with clinic staff, including a variety of perspectives again, to get that in-depth perspective. This kind of comprehensive approach will help us answer some of these evaluation questions, not just with metrics, but contextualizing the quantitative data with the qualitative data. So we'll be measuring fidelity and level of implementation, satisfaction, and contextual factors associated with implementing the program, and characterizing the determinants of implementation, looking at knowledge, attitudes, and skills. Those will come from surveys. Implementation practices that increase equitable access, we'll look at that. And then proportion of unique children, patients served by PCPs, and from a medically underserved and or vulnerable population are going to be some of the measures. For the T-chat, that's good, process and outcome data collection, we'll use the same approach in terms of quantitative and qualitative analysis. Again, starting with building our databases and analyzing existing data. Conducting quantitative surveys, and again, using a representative sample of about 250 school district stakeholders, conducting virtual focus groups with school district staff at the end of the year. And then examples of outcomes, again, include level of implementation, determinants of implementation. That means factors influencing implementation could be knowledge, attitudes, skills, experiences with the program will be assessed. And then longer term would be implementation maintenance, but we can start to look at indicators of maintenance and identifying what those may be to inform the next evaluation phase, which would be going to a year 2 or 3. And then the proportion of students served, the total by the provider type. And again, looking at the characteristics of those served by underserved or vulnerable populations to help us understand the equity of the implementation and reach of the program. And I think is that our last slide? I don't know if, is that our last slide on deck? I think we have one more.
We have 2 more, Laura. This is the CQE and the CAP. Yeah.
Yeah. Okay. Sorry. And again, using the same approach, we're again in the formative stage, building the existing database based on existing sources, and then planning and conducting 30 in-depth interviews for the end of the year. These will be with the residents, the fellows, the academic faculty, local mental health providers, and outcome examples would be experiences providing mental health care in community settings, experiences providing additional child and adolescent psychiatry fellowship opportunities, and then contextual factors associated with implementing and maintaining the workforce expansion programs. And some of the effectiveness measures could get at the number of unique patients seen among the vulnerable and underserved populations, and numbers of child and adolescent patients seen in the CAP open and filled institutions. And thanks. So these are some of the key deliverables for the process and outcome analysis. Again, for the first year, the process evaluation will be really important to make sure we understand that black box of what are we evaluating in terms of effectiveness. So the process evaluation will focus on the reach, the implementation, adoption of initiatives across the sites, including organizational and individual level influencing factors. The evaluation of whether implementation practices result in equitable participation. So this is getting a little deeper into the reach of the program. And does it reflect the racial and economic diversity of the population served? And then comparison of implementation by the HRIs and between the Texas model and other states will be another aspect of looking at our process evaluation of the program. program satisfaction, comparison of program outcomes in the total population among those vulnerable, medically underserved across the year one time period. And then the evaluation of barriers to mental health services for vulnerable populations. And that will help us actually also the flip side of that is what facilitated the implementation and facilitated participation. And that will also be highlighted in this process evaluation plan. And at the very end, through all of this, we're collecting data to conduct and inform how to conduct a budget analysis. And this sets up the longer term goal of a cost effectiveness analysis when there are more data to get a more reliable estimate of effectiveness, and also a longer term measurements are needed to conduct cost effectiveness. But the budget analysis is really looking at what are the costs of implementation of the program. And so this will be, we'll be tracking costs and looking at what data sources we have to track costs to inform this budget analysis. And that will focus on the numbers of people served in the end to look at the costs associated with those served. So that's not, that's really getting preliminary estimates of costs, and the major work for this is setting up a plan to do this going forward. There may be more questions about that we could answer, and I think, yeah, we're at the end, so open to questions, comments, feedback.
Yeah, I have one more question if possible.
Yeah.
So first of all, it's a wonderful presentation. American Association of Evaluation will be very proud of your work. I mean, it's beautiful, looks very structured and addressing all the components that were really there. I have only one question and comment. So while we are thinking about all the complex structure, evaluation structure here, and these evaluation structures are often built in a different timeline. We have a little bit different additional timelines here, such that are mandated by legislation. So when the executive committee have to prepare interim reports, which might be more frequent than what is planned, it will be very useful and important for you guys to synchronize that with what Lachelle is doing and provide her the data that is useful early toward the interim report, and say, obviously not everything is needed for that. Process evaluation, of course, it's important. Even cost evaluation is important in a different time scale as some of the outcome evaluation parts that you have, like even initial ones. So I think it will be very important to integrate these processes. So the reporting to the legislator and making it explicit what are the critical issues this legislator is looking at will be incorporated and can be immediately helped by importing your information, whatever you guys are doing. So that was my question/comment.
That's super helpful, and we can also make sure we have questions for when we start talking to key informants and stakeholders, that we're addressing the salient questions that you were just touching on. That's a really important aspect of our formative stages.
I have a question. I was just wondering, in your cost analysis, will you be able to, are you planning on at least distinguishing between the setup implementation phase versus the programmatic phase? Because the costs associated with the implementation and setup phase could be obviously higher. Now, if you mark that against the number of people served, it would be a lot higher than during the programmatic stage.
Yes.
But you need the implementation stage to get it going. And so are you planning on doing that at all?
Yes, and that is something that there are these one-time costs that do come up with new programs, that we do differentiate these one-time investment costs that are establishing the program, and then the ongoing implementation of maintaining the program. And those we can distinguish between. And the Dr. Larson, he's done very complex cost analyses of programs with the VA, and in working with him on other programs, this is how we will be collecting the data so that we can tease this apart and analyze these different stages of costs. So the ongoing implementation will be a different cost than budget analysis that decision makers will be most interested in planning for future maintenance. Did that?
One more.
Yeah.
One more question, very short one. You guys have built a full evaluation plan, which is wonderful. I'm just wondering, so the external evaluator group that will be providing external evaluation, are there particular areas that have been allocated to them, or there will be overlap and so on? Because to me, that's, I'm not sure that we really need extensive overlap. It will be kind of an important not to spend too much effort in duplicating that. But I understand also the need for fidelity and all of that. So in evaluation process itself. So can you talk about that part?
Well, I would just add that, you know, we have spoken with Molly, and we're trying to sort of understand the extent of sort of what overlap. I know we're still trying to understand everything that's been done, and I know they've talked with stakeholders, and we're planning to talk with stakeholders. And our understanding is that that's okay, that you sort of want an external perspective of what's going on, and so there may be some repetitiveness going on. But I think that's something that we definitely would love some feedback on to make sure that that is okay, because I think we do expect there to be some degree of overlap where people might be asking the same questions. And so is that okay?
Exactly. That's what I was talking about, because there will be some fatigue from the stakeholder point of view, especially non-professional ones. And we don't want to overburden our people by asking them to repeat the same things over and over again, especially if it's ongoing basis. So it will be important somehow to minimize that as much as possible.
Yeah.
Yeah, so we agree. I do see these two groups as being different. I see the internal evaluation, Dr. Lopez, being in many ways our internal management team, where we can do a variety of things and be part of those conversations that we have on a regular basis. But the external evaluation, having that arm's length from us and being able to do the work and not be confined by you know, a conflict of interest related to it, and so they can be an independent voice to the legislature, as they are also providing us ongoing input on how do we improve the projects. And so I think it's a valid point that we need to minimize duplicity and overlap, but I do see them as two distinct.
Yeah. And just if I can just give a comment, Dr. Liverson, is we are trying to work together to coordinate and make sure that you know, we don't have two entities collecting the same exact data twice. And so information that the internal evaluation is collecting, they're going ahead and sharing with the external evaluation team. And then, you know, if the internal evaluation team is collecting information, having the external evaluation team weigh in on it to make sure that it collects also any additional data they need. But as Dr. Lakey said, they're looking at it from two different perspectives. And, you know, but as much as we can, we're going to try to avoid duplicating the efforts and, you know, reaching out to the same people and collecting the same exact information twice.
I fully agree and accept. I was the one also who who voted for and spoke about having the need to have 2 evaluations, both internal and external. I perfectly understand that. The only thing I'm trying to kind of raise up the need for coordination and limiting the response fatigue, especially from our non-professional sites that we are working with, which are not necessarily clinics. For example, in a TChat, we work with school districts and others, or CPAN, we work with the clinics. It would be important to have them, not to overwhelm them with repeated information. And if we coordinate that, that's all what I was asking for. That's all.
I think it's a very valid point, Israel, and I appreciate you bringing it up. We'll continue to try to minimize that impact on the stakeholders that are having to respond. And although it may seem clear to us and the external stakeholders that, if both have some term evaluation, it can be very confusing to them. So I think it's very appropriate that you bring it up. All right. Any other comments related to the external evaluation? If not, thank you very much, and look forward to working with both of you and the rest of your teams as we make sure we're doing this right. All right. Thank you.
Thank you.
All right.
Thank you.
Thank you both. So why don't we transition then on 3E, the additional activities updates with implementation. And Lachelle, let me pull you into the conversation. You've done a lot of work to put together some quarterly reports. We didn't want to put them out there publicly today, but we're sharing them with you and want to start that process and get your feedback on it. But Lachelle, let me hand the podium over to you to talk through that.
Sure. So first of all, thank you everybody for getting me your quarterly report information. I did send out a link to some Power BI reports. So if you have a chance to review those, if you have any suggestions on how I can improve it to make it more useful for you, please let me know. The intention is to export those as PDF reports and distribute them so we have a snapshot over time. But if you want to query anything, those are available to you. The other thing I guess to mention is we are just ending up finishing up our next quarter. So in December, after you finish your month end close, if you could get me your next set, and then I will input that into the Power BI report for querying. And by now, everybody should have received all of their funding. So if anybody has any questions or concerns about the funding transfers, please reach out to me.
Very good. Any questions for Michelle? All right. Well, I think there's some other updates, but I think it may be good to go to number 5 and go through the COSH and the CPAN, TChat, and CPWE overall overview, and then we may jump back to 3E for any other updates from the rest of the consortium. So why don't we go ahead and move forward, Dr. Williams, and let's have our update related to the activities of the COSH.
Okay, that's fine. Happy to do it. Jennifer is also on. She'll talk at the end more about the resources process that we're working on. Nagla, thank you for getting the slides up since last time. Proved efficient in doing it. We want to wish everybody well, Thanksgiving has passed, but hopefully you'll have a nice holiday season. Merry Christmas and Hanukkah, even though it's all a difficult and weird time that we're all going through. So next slide is we're going to talk today about telecommunications, data management, CPAN, TChat, CPWE, and the centralized referral system. Next slide. So for Lantana, we have 11 hubs trained, 10 are operational with Lantana. 2 hubs are not yet completely using the Lantana system. One is moving towards that in the beginning of the new year. The other is just working to get their team fully staffed, and once they're fully staffed, they will be using the system. We moved to the auto attendant process, so that means that the COSH is no longer the switchboard for the CPAN, although COSH still remains the sort of, if somebody wants to speak to a live individual, Kosh will still be the default for that process. We have a standardized message now that goes out across the state. Speaking of making sure we have standardized processes, we have standardized the holiday schedule where the entire system is down. This is based off of the state holiday schedule. So that does mean that some programs such as Baylor, Baylor gives us less holidays than the state does. But we all agree that we want to have a consistent process for providers across the state. So we're all agreeing that these are the days that CPAN will be turned off, and there will be a message saying that provider can leave a message and we will get back to them at that next business day. For teams that have other days where their teams are out because of their own internal HRI holidays schedule, this is where we talk about how all teams are helping each other. So we've developed a standardized process for how teams will get coverage for when they need, when they know they have times where they need to be not being able to take calls for whatever reason. We also now have an emergency protocol in case we had this actually happen, where a team had to close that day because of a weather event. And so they needed quickly for another team to be able to manage the platform. And so we've standardized that process as well. Now that Lantana is now the switchboard, in Kosh is no longer the switchboard, my hope is that in January, I'll be able to give you reports around the metrics that we have. Remember, we have two specific metrics that we're tracking closely when it comes to the CPAN actually process itself. One is that a call to CPAN results in the provider getting back, that we get back to them within 5 minutes or less of that very first phone call. And then the second metric, that's a timed metric, is if they choose or ask to speak with the child psychiatrist in the CPAN network, that we have 30 minutes to get that call back to them. So we'll be able to start reporting out those metrics now that we have Lantana actually being the one who has through the electronical system, a way to timestamp it to show for a fact. So again, it's external to us. Lantana is the one who'll be tracking the 5-minute. Trait is the one who tracks the 30-minute process. So yes, hopefully that's what's going to happen. For data management, I'm going to talk about Trait, the governance count update for that committee, and then the collaborative efforts that we've been doing with the internal review team. Next slide. So we hopefully today, I'm waiting. There's one final person, Dr. Goodman at Baylor, who we're waiting on a signature for. Havisa's already aware of it, and he's been very helpful. So we're working on the updated contract that includes the new plans that we had for Trait to do. Trait's already been working on these processes, but we definitely want to have the contract completed. We have done payment for the services related to the build out. So CPAN in its version 1.0 is up and operational for the CPAN network. As we start to use the product and see what things that we need to improve upon, they also have been scheduling releases to make improvements. So as we start to utilize the system and we discover pieces of it that need to be improved, the Trait team is working with each HRI and then with Kosh to put out stage releases, fixes or bugs or whatnot. And they're in phase 3 currently of that overall process. I don't have the attachments related to the workflow. We discussed it last time, but today is also the day that for the TChat teams who are already using Trait, all of those outcome metrics that we, measures that we agreed that we're going to use across the state will now be available to all the teams to use for the TChat patients. So just as the research program was talking about how important it is for using measures to help improve outcomes, we're doing that as well, which I also think is pretty unique for us, that I don't know that any other state can say that they're doing something as comprehensive as this. So that's actually a release is happening today as well. We still have a few more joinder agreements that we're waiting to get. Remember, those joinder agreements for each HRI was to allow for the TChat Trait process to move forward. So we'll be reaching out to those remaining HRIs this week to kind of find out where you are in the process and see what we can do to help with that. I certainly would like to have that done before the close of the calendar year. We had our first meeting with the CPWE teams that Dr. Pliska helped get organized. so we can start discussing how to implement trait for the CPW programs. Lachelle, once she gets done with the 50 million other things that she's always tasked with doing, we're going to work with the trait team in December as well to start talking about the federal authentication system. Again, that's also part of the new contract that we have with trait to employ that. And then this TChat school screening process that we also had agreed upon to do, that will start work in the new year. Next slide. I actually don't have I know it's on my calendar, I just don't have the date in front of me. We're going to spend the next council discussing the data definitions for TChat and CPW. We've already done a little bit of work on this data definitions at the TChat level, sort of talking about what actually, and it's been good that we've been doing it, Dr. Lakey and everybody, because we are discovering that everybody does have a slightly different idea about some of these definitions. So it is important that we're all kind of trying to come together and have clarity around, you know, what is a referral? What is a completed referral? What does it mean when somebody has started services or completed services? So those are the kinds of things that we're working on. And then after we have those data definitions complete, then we can start doing the library build for those data definitions. And I do think that Molly's team has been very helpful. They sit on the council as well. And I know that we're working, and I am just a worker bee here whenever it seems appropriate for the external evaluation team to, as people were talking about, be involved, then please let us know where that makes sense, because we don't want to do double work if we don't need to, but we also want to keep it separate as it's been needed to be because they're an external evaluation team. So, but that's what we're working on there. For the internal review team, we did collaborate with Molly to create the surveys for the CPAN program. We finalized the process for the enrollment. So once a provider has enrolled in CPAN, there's a very specific survey that asks them some baseline questions about basically their comfort level in treating and managing mental health. And then we have another survey that's the first time they actually use the service so it's actually about the call itself and how well they felt that call itself went. We also have 2 other surveys for CPAN that won't happen just yet, because one of them is the end of the year survey. And so that will be, coming up in the summer of next year. And then we have another survey that we have developed, or Molly's team helped us develop, around the CPAN providers who use the service quite a bit. So we call them super users. And we're trying to decide what's the proper cadence for reaching out to those providers. Going back to that question of, we don't want to bug people by asking them too many times to complete a survey for us, but also want to make sure we sample enough that we have good data. Because as far as I can tell, my limited understanding with survey data is that you can struggle to get people to return surveys. So we're paying attention to the cadence. I'm a person that is really bad. I've never once done a survey unless I'm really mad about a service. So I do think that we want to work with Molly's team as much as possible. So that process for the enrollment and first-time caller is out, and all the CPAN teams are working towards that. And then next up, we'll try to be working on the TChat surveys that we want to do. And TChat is a little bit more complicated, because it's about who are the providers. It's the schools, but it's also the families as well who are getting the service. So we'll be talking with Molly's team in collaboration as well as we design those surveys. So the CPAN summary today, all the educational materials have been sent out to all the HRI teams as of last week. So that means the materials they have to provide information about the CPAN phone number primarily is available now for all the teams to start utilizing. Obviously, with the COVID resurgence, again, it's probably going to diminish the amount of time that we're able to go in person to practices. But these materials, I think, will be very helpful in making sure that PCPs and NPs and PAs and pediatricians, family practice doctors have it in front of their eyes so they can remember to think about calling. It's kind of like, we want to be as ubiquitous as poison control when it comes to the phone number. All the teams are seeing a steady increase in activity. We talked about how the Lantana process can help us more systematically streamline calls between institutions. And so we're happy with that. There's continued great education and outreach efforts across all the different HRIs. And remember, with our Facebook and LinkedIn page, we try to promote those activities across the state when we know they're occurring. So this is also just a reminder to all the teams that the more you tell us what activities your HRIs are doing, we'll turn that right around and send that out through CPAN Facebook and CPAN LinkedIn. I did have a presentation at NAMI, and then I presented with Dr. Lakey at the Brain Summit. So I'm very pleased that we're continuing to kind of get the word out. Next slide. So today we have over 2,400 providers across the state of Texas enrolled. This number did not change much, and that has partially to do with we had some data migration that's finally completed. All the teams have completely migrated out of REDCap and or other systems and into the trait system. Total clinics registered is 279. We've had over the span of the CPAN program running, we now have 734 calls. And so in the last month, we've had a 40% increase in calls. I do want to caution everybody that I expect with the holiday season, we'll see a dip in calls because of Thanksgiving and Christmas breaks in clinics and practices being closed. So I actually don't expect the December numbers to be higher. But hopefully as we get back into the new year, we'll see those numbers continue to, I think the word the other for the research was exponential growth. I do hope that we'll continue to see, I'm probably a little more cautious, not exponential growth, but clear and steady growth in the calls for services. This is again just a breakdown in the reasons for why PCPs are calling or who is calling us, and it still is primarily physicians calling, although there is a number of different other types of individuals who will get on the phone and ask for a CPAN assistance. The reason for the call is still largely about behavioral and medication management, which again is kind of makes sense, and we're happy to see that they're not calling us about things that we can't help them with. Thankfully, they are calling us about things that we actually have the ability to help them with. So those numbers and reasons for call have not really changed. Next slide. There are still upwards of half of the calls are being asked. They do want to speak to the child psychiatrist. So when you start to think about what is the CPAN team structure, each hub need to look like, we still are seeing that there is a lot of desire and need to speak with a child psychiatrist. And then the other half is either the therapist or the resource coordinator. In talking with Dr. Tran, our pediatric consultant for COSH, when we were asking her about this question, I think her perspective was very important. One of her thoughts was that, again, because mental health is still an area where many providers feel very uncomfortable with, they themselves may not feel as comfortable with providing a guided behavioral intervention in office, and maybe feel more comfortable with sticking to more of the medical model of what they sort of are expecting and knowing how to do as a physician. So we think that's one reason for why we're not getting as many requests for them to sort of manage something behaviorally in office. But we do just think that's another way where we can target some education out to the providers over time so that they can sort of have that assistance and maybe call us for that a little bit more frequently. And then when you sort of look at where the referral recommendations are when they are asking for referrals, you can see that about 37% are being referred to a local health provider. Sorry, I'm just looking at a message and I'll answer the question in just a second. I'll say it and I'll answer it. So there is still, which is you should expect in child mental health, that you don't always need a child psychiatrist to actually provide services. There's plenty of other evidence-based treatments that require other types of clinicians. So, still, a good percentage of our providers referrals are recommending that they see usually a therapist to sort of help them manage the behavioral health issue. And I do think it's developmental, as so somebody asked me in the chat, do you think it's a developmental thing? And yet we do think that it's possible that they may evolve over time. And that's what Dr. Tran, our pediatric consultant, is really hoping, is that as providers start to use the service, start to feel more comfortable, they will start to ask for additional kinds of help in management as they start to get their sea legs under them. I do think that that is borne itself out, particularly with MCPAP, because that's the most studied, consultative network in the country, and they have several papers on their work, and they do state that when they have surveyed their own pediatricians and primary care doctors in Massachusetts, that as they get to use the program over time, they do start to feel more comfortable in doing more and different things. And so that's what we would hope to see as well. So this one, again, Dr. Lakey, hopefully maybe by the next meeting, we'll be able to answer your question that you've asked me for 3 months, and I've told you I can't answer it for you. But I think actually the legislature might be happy to hear that, 44% of the time we're not actually recommending a medication be utilized, because again, there's a lot of evidence-based treatments for child mental health disorders that don't include psychiatric or psychotropic medications. So as a child psychiatrist, one of the things that we frequently do is actually tell people to stop taking medications. I know that's not our street cred, but it is at least true at the academic center level. And then continue or change dose or start and taper. Dr. Lakey wanted to know, was that additive or not? And that's a question that we hope to be able to answer in the near future. Anything about CPAN before I move on to TCHAP? Okay, so TCHAT, as we've talked about, we have 96 ISDs across the state of Texas. Each of the HRIs is definitely looking to expand out into additional ISDs in the upcoming few months. Several of them have some already in progress. Others are working to get there. We have worked, as I said last time, with the TEA, and that we're trying to have each of the HRIs get set up with their regional TEA leadership and educational support centers to really help partner and find the additional ISDs in areas of Texas that are low resource, speaking of that idea of access to care. And is there any, as the external evaluation team was like, inequities there, we're trying to be very mindful of, providing this resource to hopefully as many of the under or low resource areas as possible. And so that is a work that's going on. But at this point in time, we have 96 and we do expect to grow. The total referrals for TCHAT have also grown, maybe not exponentially, but definitely by quite a bit. And so this is almost 900 referrals for TCHAT, basically in a span of 2.5 months, because most of the TCHAT services didn't really start in earnest until September. And this is, again, not unexpected. During the summer, school is quiet. Kids, even if the kids are in summer school or whatnot, they're not often doing as much intensity with mental health services. As kids go back to school and stress levels rise, the need for the services increase. So we're in our peak that we have just with child mental health. There's 2 peaks. There's one in October, November, and there's another one in March, April, corresponding mostly with when school report cards come out, frankly, if you look at the data. So we are seeing an increase, and this is actually with some of the teams of TCHAT not been able to start yet because of operational and hiring issues. So we do expect that to increase. The average age of the youth that's being seen so far for TCHAT is around 11 or 12. I was not too great at doing some of the data, but I'm actually happy to report that we now have hired the project manager who starts actually today. She's at her orientation at Baylor, I think. So she's gonna be able to help me provide you at this next meeting with a much more detailed breakdown of some of the data that we've been collecting over the last few months when it comes to TCHAT as well. This is partly because we still have teams providing data and metrics in some disparate ways, and we're trying to get that all under one umbrella. But again, also, we don't have too many kids who finished the service yet, because as we know, even though it's a short-term service, as I said, most of these kids just started with their care in the last 6 weeks, and they can have up to 4 visits. And so a lot of the kids who have gotten their first appointment haven't run through the entire service delivery for TCHAT yet. So we do expect that at the next meeting, I'll definitely be able to give you at least the grade level, the gender, and where, what is the percentage of completed or not with the services, as well as the service provider type, because we are keeping track of that right now. I'll be able to give you some better metrics in January. Next slide. And this was the map. And since this map was created, I know that Dan and Lachelle have been working to actually improve upon it. And so we hope to see this map and the little teardrops spread out of the state over time. Next slide. So as I said, we're working with the CPWE team leads at each of the HRIs to talk about how best to utilize that. We had our first meeting on the 17th, and we have our next meeting again early December. And we will work with, once we have a good sense from each of the HRIs how we're going to utilize TRAIT, then I'll talk with TRAIT. I've already had some preliminary meetings with them, but I wanted to save the final meeting with TRAIT until I heard from all the HMRs how we're planning to do this. And so the plan is to utilize TRAIT as is and use the same measures that are employed for TCHAT and CPEN. So again, we start talking about metrics and the ability to compare. We're going to use the same outcome, the same scales, so that again, there is an opportunity over time to maybe look at how youth are doing across a variety of these services. And I think a way that's never been done before, as far as I understand. So next slide. Jennifer, do you mind maybe providing a little update here?
Yes. Hello, everyone. Just to remind you what WellNeti is, it is the platform which we're going to use to share resources across the state of Texas. So whether we cover for each other or just need help identifying some resources in the rural areas, we will use WellNeti as that platform. And so we're going to be working with all the LMHAs, insurance carriers, different hospital systems, private providers. We're going to be working with a lot of people across the system to get them all into one database. And so one thing that we're going to be doing coming up at probably the next state meeting that Dr. Williams and I have with everyone is to present the columns of a spreadsheet that we're going to be asking, such as, would you like to search by insurance type, location, specialty, whether they have telemedicine, the different items of what you would like to search for, what you would find most useful for that. And so once we do that, it won't take very long to build it and put that together. And then we will just start asking for the resources that you already have and getting them. And then we'll be working with the local LMHAs and some other people throughout the state to help add additional resources that you don't already have. Obviously, we don't already have them across the state, or we wouldn't have a need for this. So that is the purpose of WellNeti. I think you'll find it very useful. We'll have a dashboard for WellNeti so we can track in it how many referrals did we look up for LMHAs, what percentage did we not find a referral for, and what locations those were, so we can try to locate and pinpoint some places that were really lacking in referrals. Where was the nearest referral? We can search by distance and location with that. So I think it's going to be useful information as we try to locate and fill some gaps across the state. So that's going to be the next steps in that. Another thing we have heard from some of the HRIs is that the ability to contact some of the parents. So it looks like the counselors, they make the first attempt to contact the families and they get them, and then we are to then call them and try to get them for appointments. And we're having a hard time engaging with the parent in some cases. So there is another thing that WellNeti can do where it's a texting application. The parents don't have to download anything, but if we have the phone number, which we do, we can send a text message to the parent if the parents opt in and say, yes, they like to receive it. And they can say, are they interested in services or are they not with the TCHAT before engaging in that. So before we do any of that, again, we will present this at the state meetings that Dr. Williams and I have, so you can see what it looks like and see if you think that would be helpful. If you are one of the HRIs having difficulty contacting the families, this will be something else that we can offer as a communication, because I know that a lot of people in the rural areas aren't able to have internet and things, but they can text. And so we can get, you can get really fancy on it and ask them a lot of questions on it, or you can just do the simple, if you are interested, what's the best times to call, things like that. So that's the summary of WellNeti. Does anybody have any questions on that?
Well, that would be awesome. I think that's, we found that lots of people like to use their phone, even if they do have the internet.
Mm-hmm.
And so providing them with that ability is going to be really, really nice to give them that option.
Very cool.
Well, I said we will be having these conversations with our TChat and teams across the state. We have our next state meeting December 11th for both CPAN and TChat. All right. Thank you. Thanks, Jennifer.
Yeah. Thanks, Laurel. Any questions related to the cost, TChat, CPAN? Hearing none. Steve Plitzka, I think I'm going to pull you into the conversation a little bit. Did you have an update about CPWE that you wanted to share with the group?
There we go. Yeah, if we can pull up the now this data set's not quite complete yet because we got some late data early this morning. We need to add JPS to this, but overall, this gives you the sense of which entities the HRIs have approached and are likely either have an MOU or are in process. Andy Harper, are you on?
Yes.
Yes. Actually, you guys have an MOU signed. Is that correct?
Yeah, that's correct. And I thought I had sent that to you with Brazos Valley MHMR.
And what FTE is that going to be? Resident FTE?
So initially it'll be just we won't have residents until 2021. So yeah, so initially it'll be just the faculty.
Faculty, what faculty FTE, just for the sake of
0.5.
0.5, okay. And actually that does remind me, I guess in the future I need to add a column for the faculty FTE as well. But it's self-explanatory. If we scroll to the right,
Let me just jump here and say we're very happy to let everybody know that our residency training program was approved, and we are recruiting residents that will go into CPW this coming summer. So we just got, and Andy Harper led this effort, and it was without any comments. We got accreditation to start the program. So just a small comment. Thank you, Andy.
Congratulations, Israel.
Okay.
I know that's a big step for you guys. Congratulations.
Yes, indeed. All right. One question came up for the UTRVG folks for Tropical Texas Behavioral Health. It looks like that program is predominantly adult. Is that correct?
It is, but if you look at the numbers, we're seeing so many people. You know, we really do see a lot of children and adolescents.
Are those that 4.7? Those are all newly funded by CPWE. Those are not ongoing rotations that you had.
Yeah, they're new ones.
They're new ones. Okay, good. All right.
So Michael, I think there may be something wrong with that last column there of 0.102%. I think it's. I saw somewhere else it would maybe 10%, but
yeah, I'm sorry. It should be reading 10.2.
Okay, 10.2. That makes sense. And congratulations for those huge numbers. You know, you're almost getting up to 3,000 patient encounters. And so 10%, you're almost 300 kids. And so congratulations.
Thank you.
Very good. So the other issue with CPWE, of course, we're gathering, thank you everybody for gathering this data manually from each of your sites. Sonia or Danette, do you have any update on the centralized data gathering from HHSC?
So this is Danette. I don't think that Sonia is on.
Oh, okay.
I didn't see her get on, and I know she wasn't here earlier this morning. So I do not have an update. I do know that I got an inquiry over the weekend indicating that they have an update and to schedule a meeting to talk about it. So there should be one.
I'll email Sonia and try to get that going.
Okay.
And of course, we're until we get that in place, we'll be continuing each month. I'll be sending out this spreadsheet to update. And we're always going to look at total encounters and total unique patients through whatever the end of the month is. And of course, I'll add a faculty column to the next report as well. And that's all I have.
Yeah, no, very good. And again, with like all the other programs, you really see these programs taking off right now. But,
This is Luann, and I just have a quick question on Texas A&M and Dr. Harper. So it would be safe to say that on this chart, under Texas A&M University, we would put Brazos Valley MHMR, and that is an existing MOU. Would that be a correct assumption?
So yes, put Brazos Valley. We have the MOU is sent to them for final sign-off. Yes.
Okay. And then in terms of the University of North Texas, Dr. Pardovic and Dr. Chasse, I know that you all had also been working with Tarrant County, and I didn't notice that on the chart, and I wanted to see if we.
The MOU is being developed right now. They are getting ready to gear back up, so we should have residents there sometime. I'm hoping early March, maybe late February, to get the MOU through all of the different attorneys. So I didn't put that down because their MOU is still being debated by the attorneys.
Okay.
Because Ellen, look at, because I got a spreadsheet from you this morning. It looks like you appended John Peter Smith to the bottom of the list. And it says, yes, MOU status, yes, monthly FTE 0.6.
Yes.
So that's what you're currently doing. Now, are you having another program you're doing an MOU with?
We're going to do that, yes, with the Tarrant County MHMR. So we'll have two programs.
Two programs, okay.
Yeah, I just wanted to make sure that that was included. What we're doing is we're preparing an information for the biennial report. We wanted to make sure that all the ARIs were included in that, as well as just the current status of where you're at with your MOUs, as well as individuals that are being seen. So thank you.
And I think just to confirm, so UNT has two rows. Their current program at John Peter Smith, which is underway and has the 98 unique clients served, and then the program with, what is it called, Tarrant County MHMR?
Yes.
Yes, that'll be a row that will have nothing but in process on it.
There'll be a second row. And we've identified the director there. So we're the child unlicensed director. So we're ready to go. That'll be 100% child also.
Okay. So Luann, is that clear to you?
Yes, thank you. And we'll update those numbers on the chart and make sure that that all goes in. So everybody gets credit for all the work that you're doing on CPWE.
Thank you.
Very good. Any other comments on this before we move on to the next item? Hearing none, I'm going to jump back up to 3E for any additional updates, and would open it up. Any updates from any of the executive committee about other programs are putting on, educational activities, anything else that you'd like the rest of the executive committee to know about?
Dr. Lakey, I wanted to update everyone that we submitted for our application for accreditation for our child fellowship on November 19th at the deadline.
Very good.
I'd like to make a quick, this is Jeff Matthews in Tyler. I'm going to be leaving UT Health Science Center in Tyler and going to Austin, where I'm going to take over the role as the Chief Medical Officer at HHSC State Hospital System. So I want to thank everyone for the opportunity to work with a really great group that's going forward and really accomplishing a lot of things. And I hope to have some role in the future. So thank you very much. And we'll have an interim chair, Dr. Bryant, who will be taking my place in this committee. I'm assuming, does it need a nomination or approval, or is that automatic due to the legislature?
That would be automatic, but thank you, Jeffrey. You've been here from the beginning, before we were the consortium, and appreciate all the work that you've been doing in East Texas. And so look forward to continuing to work with you in this new role.
All right, thank you.
Sorry to lose you from this committee, Jeff.
Well, not necessarily.
Congrats, Jeff.
It's some different role or a peripheral role, but thank you.
Good luck in the different role.
Well, welcome to Austin, Jeffrey.
Thank you.
Yeah,
We're glad to have you in Austin.
All right, this is Danette, and I just want to reflect back on our really good conversation this morning about the research efforts that are underway, and I consider those to be highly valuable. And as we talked about, kind of a late breaking component that was added to this, we had talked and deliberated, I want to say back in maybe August, about the importance of using person-centered language as we think about the unique way in which we are approaching the research in this initiative. And we had agreed to use the language of participants as opposed to subjects. And we had also talked about engagement as opposed to recruitment. And so I would just suggest that we take great care in terms of making that change in language, and would just ask us to give consideration to that going forward.
Annette, thank you so much for the comment. It may take a time or two. We'll strive to do it.
Okay, thank you so much. I appreciate it. And I really look forward to the value of this project. I think it's going to be incredibly informing on two important fronts that to address improvements to mental health care for people, and to inform guidelines that go forward.
Thanks.
Thanks, Danette. Appreciate that. Any other updates from any of the executive committee members? All right. Luann, is there anything else that we need to accomplish in this meeting today?
I just want to thank everyone for all of your assistance as we've been counting you the last for recent data and information to include in the biannual report. As Dr. Lakey mentioned earlier, it is due tomorrow. So we are diligently working on last minute changes and edits and modifications. As soon as we get that prepared and ready to go, we will make sure that you all also receive that information. And so I just want to say thank you for that, and hope that all of you had a wonderful time off last week. Obviously, we've hit the week after a holiday. We've hit the ground running with our meeting this month. We'll have another one in December. And by that time, we should have some additional information to share with you, just in relation to a lot of the reports that we've done and some of the quarterly information that we've received. So thank you very much.
Do you have any tentative dates for the December meeting? Because that month fills up pretty fast.
Yes. Oh, actually, I take that back. It's not till January. Whoops.
Okay, that's because I know I hadn't seen it. Good. I'm glad I asked.
My bad. I was trying to rush us through. So no, it's not going to be until January 15th. So you all will get a break from a consortium meeting in December. So obviously, since it will be in January, we'll have more to update you on. So thanks very much, everybody.
Thank you.
Just a little bit with it.
Yeah, thank you.
Okay.
So our team will be finishing up that report this evening. And so if you get any emails from me or my team this afternoon, if you could respond to those very quickly, I would really appreciate it as we finalize this report.
Thanks to you for being so supportive, all of you.
No, thank you all. Anything?
Just to double check, that's Wednesday, January 13th is the next meeting?
It's January 15th.
15th. Oh, there it is. Okay, thank you.
Mhm.
Sorry. All right, got it. Thank you.
Just a question. In our report, do we also highlight the setup of what we heard earlier? For example, external evaluation program?
Yeah, so we have a section in internal and external. We talk about it, the research, all the projects that we're part of.
Well, I was specifically highlighting the evaluation program because that demonstrates how actually our fiduciary and programmatic responsibility that we are taking in administering the taxpayer money and so on. I think it will be kind of an important point that legislator would like to see it at least, or be highlighted, that we have set up a program from the start to help us to make sure that we're doing the right thing.
Yeah, and so in the report, we have a section here. The EC also believed that an external evaluation team with no potential conflict of interest was needed to provide a frank and unbiased analysis of all its initiatives. In August 2020, an external evaluation UT System released an RFP to select an entity to conduct this external evaluation, which will be provided to policymakers and the consortium members. Then it goes on to talk a little bit more about it. So we've included that language.
Thank you. I missed that. Thanks.
No, you haven't seen it yet. So yeah. So but we think that's important, and we're including it.
And I do want to also give a shout out to Dr. Taminga, Dr. Nemiroff, and Dr. Trevedi, because you provided some very extensive information about both of the research networks, and so extensive that it will actually be posted for visibility on the internet. And so we just thank you so much for that as well.
Any other comments for the good of the order? Good for the consortium? Hearing none, thank you all for your time this morning. We'll give you back your lunch hour, and we look forward to talking to you in January. And again, if I send you any questions today, if you could get back to me, that would be greatly appreciated as we finalize this report. Okay?
Thanks for the good meeting. Bye-bye.
Thank you
Merry
all.
Christmas, everybody.
Bye.
Happy holidays.
Bye-bye.
See you.